This is Chapter 9 of the ATI, Maternal Newborn Medical Conditions. Unexpected medical conditions can occur during pregnancy. Awareness, early detection, and interventions are crucial components to ensure fetal well-being and maternal health. Unexpected medical conditions include cervical insufficiency, hyperemesis gravidarum, anemia, gestational diabetes, and gestational hypertension. Cervical insufficiency, or premature cervical dilation, is a variable condition whereby expulsion of the products of conception occurs. It is thought to be related to tissue changes and alterations in the length of the cervix. Risk factors: history of cervical trauma, short labors, pregnancy loss and early gestation, or advanced cervical dilation at early weeks of gestation. In utero exposure to diethylstilbestrol ingested by the client during pregnancy, and congenital structural defects of the uterus or cervix. Expected findings: pink stained vaginal discharge or bleeding, possible gush of fluid, uterine contractions with the expulsion of the fetus, and post-operative, which is cerclage, monitoring for uterine contractions, rupture of membranes, and manifestations of infection. Diagnostic and therapeutic procedures: an ultrasound showing a short cervix less than 25 millimeters in length, presence of cervical funneling, which is beaking, or effacement of the cervical, and OS indicates reduced cervical competence. Prophylactic cervical cerclage is a surgical reinforcement of the cervix with a heavy ligature that is placed submucosally around the cervix to strengthen it and prevent premature cervical dilation. Best results occur if this is done at 12 to 14 weeks of gestation. The cerclage is removed at 36 to 38 weeks of gestation or when spontaneous labor occurs. Nursing care: evaluate the client's support systems and availability of assistance if activity restrictions or bed rest are prescribed. Assess vaginal discharge and monitor client reports of pressure and contractions. Discharge instructions: adhere to activity restriction or bed rest. Increase hydration to promote a relaxed uterus. Dehydration stimulates uterine contractions. Avoid intercourse. Monitor for cervical or uterine changes. Cervical cerclage might be required, often placed at 12 to 14 weeks gestation and removed at 36 to 38 weeks. Monitor client's report of pressure and contractions. Adhere to activity restrictions. Avoid intercourse. Report findings to the provider. And the follow-up for observation and supervision. Plan for removal of the cerclage between 36 and 38 weeks of gestation. Hyperemesis gravidarum is excessive nausea and vomiting, possibly related to elevated HCG levels that is prolonged throughout the pregnancy or that is excessive and causes weight loss, dehydration, nutritional deficiencies, electrolyte imbalances, and ketonuria. There is a risk to the fetus for intrauterine growth restriction, small for gestational age or preterm birth if the condition persists. Risk factors: maternal age younger than 30, multifetal gestation, gestational trophoblastic disease, psychosocial issues and high levels of emotional stress, clinical hyperthyroid disorder, diabetes, GI disorders, and family history of hyperemesis. Expected findings: excessive vomiting for prolonged periods, dehydration, weight loss, increased pulse rate, poor skin turgor. Lab test is a urinalysis for ketones and acetones, which is breakdown of protein and fat, is the most important initial lab test. Elevated urine specific gravity. Chemistry profile: revealing electrolyte imbalances such as sodium, potassium, and chloride reduced from low intake, metabolic acidosis secondary to starvation, and metabolic alkalosis due to excessive vomiting, elevated liver enzymes and bilirubin level. Thyroid test indicating hyperthyroidism, and a CBC, elevated HCT concentration because inability to retain fluid results in hemoconcentration. Nursing care: monitor INOs, assess skin turgor and mucous membranes, monitor weight, vital signs, and have the client remain NPO. Medications. Give IV lactated ringers for hydration. Give pyridoxine, which is vitamin B6 and other vitamin supplements as tolerated. Use antiemetic medications like metoclopramide cautiously for uncontrolled nausea and vomiting, and use corticosteroids to treat refractory hyperemesis. Discharge instructions. Advance to a diet of clear liquids and bland foods once the vomiting has stopped. Advance the client's diet as tolerated with frequent small meals. Start with a diet bland that indicates dry toast, crackers, and baked chicken, and finally to a normal diet as tolerated. In severe cases, enteral nutrition per feeding tube or post-total TPN can be considered. Iron deficiency anemia occurs during pregnancy due to inadequacy in maternal iron stores and consuming insufficient amounts of dietary iron. The risk factors is less than 2 years between pregnancies, heavy menses, diet low in iron, and unhealthy weight loss programs. Expected findings is fatigue and weakness and craving unusual food, which is pica. The lab test is HGB, which is less than 11 in the first and third trimesters and less than 10.5 in the second. HCT is less than 33%, and blood ferritin is less than 12. It's present in presence of low HGB. The nursing care is the recommended iron intake for pregnant clients is 27 milligrams a day. Prenatal vitamins typically contain 30. If maternal iron deficiency anemia is present, increased dosages of 60 to 100 milligrams can be required. Increased dietary intake of food rich in iron, which is legumes, dried fruit, dark green leafy vegetables, and meat. Educate the client about ways to minimize GI adverse effects. Medications. Ferrous sulfate iron supplements. Take the supplement on an empty stomach and take with orange juice to increase absorption. Adhere to a diet rich in vitamin C containing foods to increase absorption. Increase fiber and fluid intake and diet to assist with discomforts of constipation. Parenteral iron therapy. For pregnant clients who cannot tolerate oral iron, severe anemic clients can receive blood transfusion. Gestational diabetes is an impaired tolerance to glucose with the first onset or recognition during pregnancy. The ideal blood glucose level during pregnancy should range between 60 and 99 before meals or fasting and less than or equal to 120 after meals, 2 hours after meals. Findings of diabetes can disappear a few weeks following birth. However, approximately 50% of clients will develop type 2 diabetes later in life. Increased risk to fetus. Macrosomia, birth trauma, electrolyte imbalances, and neonatal hypoglycemia. Infections, this could be urinary or vaginal, related to increased glucose in the urine and decreased resistance because of altered carbohydrate metabolism. Ketoacidosis from diabetogenic effect of pregnancy. This is increased insulin resistance, untreated hyperglycemia, or inappropriate insulin dosing. Hypoglycemia is caused by overdosing in insulin, skipped or late meals, or increased exercise. Hyperglycemia, which can cause excessive fetal growth, is macrosomia. The risk factors is obesity, hypertension, glucoseuria, maternal age older than 25, history of diabetes, and previous birth of an infant that was large or stillborn. Expected findings. Hypoglycemia is going to cause nervousness, headache, weakness, irritability, hunger, and blurred vision. Hyperglycemia is polydipsia, polyphagia, polyuria, nausea, abdominal pain, flushed dry skin, and fruity breath. Physical assessment findings. Hypoglycemia, shaking, clammy pale skin, shallow respirations, rapid pulse, hyperglycemia, vomiting, excessive weight gain. Lab tests. Glucose screening test is 1 hour glucose tolerance test. It's 50 grams oral glucose load, followed by plasma glucose analysis 1 hour later, performed at 24 to 28 weeks of gestation. Fasting is not necessary. A positive blood glucose screening is 130 to 140 or greater. Additional testing with a 3 hour oral glucose tolerance test is indicated. Oral glucose tolerance test. Following overnight fasting, avoidance of caffeine, and abstinence from smoking for 12 hours prior to testing and abstinence from a fasting glucose is obtained at 100-gram glucose load is given. A serum glucose levels are determined at 1, 2, and 3 hours following glucose ingestion. Presence of ketones in urine to assess severity of ketoacidosis. Okay, so diagnostic procedures. Biophysical profile to ascertain fetal well-being if non-stress test is non-reactive. Amniocentesis with amniotic fluid, phosphatidylglycerol measured to determine fetal lung maturity, and non-stress test to assess fetal well-being. Monitor the client's blood glucose, monitor the fetus. Medications. In contrast to clients who have type 1 diabetes, clients who have GDM are managed initially with diet and exercise alone. If glucose levels are persistently high, insulin is begun. Oral hypoglycemic therapy is an alternative to insulin in clients who have GDM who require medication in addition to diet for blood glucose control. Most oral hypoglycemic agents are contraindicated for gestational diabetes, but there is limited use by glyburide. The provider will need to make the determination if these medications can be used. Client education. Perform daily kick count, adhere to the appropriate diet, including standard diabetic diet and restricted carb intake. Dietary counseling by a registered dietitian should occur. Exercise, perform self-administration of insulin. Gestational hypertension. Hypertensive disease in pregnancy is divided into clinical subsets of the disease based on end organ effects and progresses along a continuum from gestational hypertension, preeclampsia without severe features, preeclampsia with severe features, and eclampsia. Vasospasm contributing to poor tissue perfusion is the underlying mechanism for the manifestations of pregnancy hypertensive disorders. Gestational hypertensive disease and chronic hypertension can occur simultaneously. Gestational hypertensive disease are associated with placental abruption, kidney failure, hepatic rupture, preterm birth, and fetal and maternal death. Gestational hypertension, or GH, which begins after the 20th week of pregnancy, describes hypertensive disorders of pregnancy whereby the client has an elevated blood pressure at 140/90 or greater recorded on 2 different occasions, at least 4 hours apart. There is no proteinuria. The presence of edema is no longer considered in the definition of hypertensive disease of pregnancy. Blood pressure returns to baseline by 12 weeks postpartum. Preeclampsia. Traditionally, preeclampsia has been diagnosed with proteinuria occurs with GH. However, current research indicates that clients who have preeclampsia may not exhibit proteinuria. Therefore, the diagnosis of preeclampsia can be made in the absence of this finding. Reports of headaches might occur along with episodes of irritability. Edema can be present. Severe preeclampsia consists of blood pressure that is 160/110 or greater, proteinuria greater than 3+, oliguria, elevated blood creatinine greater than 1.1, cerebral or visual disturbances, which are headaches and blurred vision, hyperflexia with possible ankle clonus, pulmonary or cardiac involvement, extensive peripheral edema, hepatic dysfunction, epigastric and right upper quadrant pain, and thrombocytopenia. Eclampsia is severe preeclampsia manifestations with the onset of seizure activity or coma. Eclampsia is usually preceded by headache, severe epigastric pain, hyperflexia, and hemoconcentrations, which are warning manifestations of probable convulsions. HELP syndrome is a variant of GH in which hematologic conditions coexist with severe preeclampsia involving hepatic dysfunction. HELP syndrome is diagnosed by lab tests, not clinically. H is hemolysis. Hemolysis results in anemia and jaundice. EL is elevated liver enzymes, resulting in elevated alanine aminotransferase, or ALT, or aspart transminase, which is AST, epigastric pain, and nausea and vomiting. LP is low platelets, less than 100,000, resulting in thrombocytopenia, abnormal bleeding and clotting time, bleeding gums, petechiae, and possibly disseminated intravascular coagulation. HELP syndrome. Risk factors. No single profile identifies risk for gestational hypertension disorders, but some high risks include the following: maternal age younger than 19 or older than 40, first pregnancy, extreme obesity, chronic renal disease, chronic hypertension, diabetes, rheumatoid arthritis, and systemic lupus. Expected findings: severe continuous headache, nausea, blurring of vision, flashes of light or dots before the eyes, hypertension, proteinuria, periorbital, facial, hand, or abdominal edema, oliguria, hyperflexia, epigastric pain, and right upper quadrant pain. Lab findings: elevated liver enzymes, increased creatinine, increased plasmic uric acid, thrombocytopenia, HGV, and hyperbilirubinemia. Lab tests are liver enzymes, blood creatinine, BUN, and uric acid, CBC, clotting studies, and chemistry. Diagnostic procedures: dipstick testing for urine for proteinuria, 24-hour urine collection for protein and creatinine clearance, non-stress test, contraction stress test, biophysical profile, Doppler blood flow analysis, and daily kit counts. It is recommended that daily low-dose aspirin therapy be initiated late in the first trimester for clients who have a history of early onset preeclampsia. Antihypertensive medications is methyldopa, nifedipine, hydralazine, and labetalol. Avoid ACE inhibitors and angiotensin II receptor blockers. Anticonvulsant medications, magnesium sulfate, medication of choice for prophylaxis or treatment to depress the CNS and prevent seizures in the client who has eclampsia and severe preeclampsia. Use an infusion control device to maintain a regular flow rate. Monitor blood pressure, pulse, respiratory, deep tendon reflexes, level of consciousness, and urinary output. Monitor for manifestations of magnesium sulfate toxicity, which is absence of patellar deep tendon reflexes, urine output of less than 30 milliliters an hour, respirations less than 12, decreased level of consciousness, and cardiac dysrhythmias. If magnesium toxicity is suspected, immediately discontinue infusion. Administer antidote of calcium gluconate or calcium chloride. Prepare for actions to prevent respiratory or cardiac arrest. There can be initial feelings of flushing, heat, sedation, diaphoresis, or burning at IV site with the magnesium sulfate bolus.